To hernia patient. Now we start. Hello and welcome to Hernia Patient Support Group and to our live chats. So I'm Jackie. I'm one of the admins of the group, and I'm delighted to be joined tonight by Ms. Stella Smith from Manchester, who is a friend of ours and who is President-elect of the British Hernia Society. So welcome, Stella, and thank you very much for joining us tonight.
Thank you for having me.
Thank you. This session is being recorded and will be available to watch on YouTube shortly afterwards. So Stella, when we find out we've got a hernia, it can be really quite a daunting experience. And with the best will in the world, I know you guys, and I know that you're all lovely people, but when we walk in that consultation room, it's like you're a complete monster and everything we've thought about has been forgotten.
Yeah.
So I think for us, we often get asked, what should we ask a surgeon when we get there? But I like to think that preparation for the appointment is going to mean it's a much more productive appointment, but more productive consultation. So we suggest that people think about it at home, how the hernia affects them in every way, because you want to manage our expectations. We can't promise something, can you, that you're not going to achieve. So surgery is not going to fix everything, is it?
No, I think that's really important actually. So I think when you're thinking about hernia, you need to think about that in the context of everything else that's going on in your life, and about all your other medical problems. And I think, whenever you're thinking about your hernia and about surgery and about the potential for having surgery, sometimes that's really big surgery as well. It's about sort of considering what you want to get from that. How does your hernia impact your life? What is it that you want to change? And for some people, they will have a hernia, and that will be the least of their problems in terms of their general health, and the way that the general health impacts on their life. So I think that that's probably one of the first things to think. Um, just going back a little bit, when patients are coming into clinic, one of the most useful things that patients can do is write stuff down. And write down sort of a list of questions for your surgeon.
Yeah.
What is it you want to get from your surgery, but also, what is it you want to get from that consultation, particularly within the NHS. Like, we're so time pressured with our consultations, and we all know that there's more patients than our surgeons can manage, or any of our healthcare professionals can manage, certainly within the NHS at the moment. So it's worth trying to maximise the time that you're in that room, and bring someone else with you as well. Two pairs of ears are so much better than just one. And you'll walk out of your consultation and think, what did she say again? And if you've got somebody else with you, they will be able to recount some of what was said, but also they can prompt you with those questions that you wanted to ask.
Yeah. Do you find though that sometimes patients won't be honest if they've got a loved one with them about how much the hernia is actually impacting in their life? So having it written down, they can pass the paper to you to read, would actually help
Yeah, I mean, I tend
as
to
well.
work with a piece of paper with the patient. I'm like, okay, let's just go through these one by one. And
Mm.
often I'll have answered a lot of the questions during the consultation. At the end, we get the piece of paper back out again and go, okay, what haven't we covered on here? And I guess it's about the individual, isn't it? About whether, bringing someone along works for them and who that person is. I mean, I don't mind who comes into that room. It can be a friend, it can be, it can be a member of family, it can be someone from their religious group. It doesn't bother me at all. They can bring anybody they want. They can bring, 4 or 5 people if they want to. But yeah, I often find, I think particularly for people who are quite worried about that consultation or think it's going to be quite complex, and definitely bringing someone along, I think, helps just with recounting the information afterwards.
Yeah. And I think sometimes by doing this and questioning yourselves before the consultation, you've got an idea that if the hernia isn't impacting your life too much, do you actually want to put yourself through having an operation?
Yeah, and I think having that conversation about what exactly does this operation entail? How long am I going to be in hospital for? How much pain am I going to be in? How long is that recovery going to be? How is that recovery then going to impact other aspects of my health? So, the lack of mobility and the inability to get around for those patients who've got other healthcare conditions that are already limiting their mobility, that might be a really big thing, because they might think, well, hang on a minute, if I stop walking, that's not going to be any good for my heart or my lungs or my other sort of musculoskeletal, so my arms and my legs that already are not working as well as I'd like them to. So I think that bit's really important.
Yeah. Okay. So when we do come to see you, we need to know what the hernia is. So do you do any tests or anything, or you can actually, on most hernias you can see it, can't you? You can see that they're there. Do you need to organise scans sometimes, because some of our members find that they're concerned that that hasn't been done, but obviously you can see the hernias there.
So I think it depends on the hernia. I think is the first thing to say. It as a general rule with a consultation, when you walk into that room, your surgeon is often going to run through everything from the square one. Okay, when did this start? Okay, just walk me through all the different steps, particularly with people who've had a lot of surgery and things before. They'll want to know what happened, when did it happen, and when did this hernia appear, and has someone had a go at fixing this before? In terms of tests and investigation, and when I go through all sort of the past medical history as well, that what I mean by that is, what other medical conditions that people got, what sort of medications are they on, what's their lifestyle like as well, are they working, are they not working, have they got kids, have they not got kids, how, and that sort of gives, for me as a surgeon, a bit of a sense of, what can I what how is this operation, if we're going to do one, going to impact on this
Yeah.
person's life or not operating.
Yeah.
um, and then in terms of, most surgeons will always examine the patient in front of them. I think most people expect to be examined. And then it depends on the type of hernia. Groin hernias and things, perhaps it's less important to do sort of tests and investigations, but anything where there's been lots of surgery before, and there's big hernias coming out the front of the tummy wall, absolutely there'll be a CT scan is normally what people do, or an MRI scan, but usually a CT scan.
Okay, so patients like to know then how the surgery is going to be performed. I don't think they're particularly bothered about how you do it. Is it going to be an open procedure, a laparoscopic, or a robotic procedure?
Yeah.
And then they want to know, are you going to use mesh?
Yes.
And if so, what mesh? I mean, I always get asked a lot about what do I think about this mesh? And I will say, well, what benefit has that particular brand of mesh got for you that a different one wouldn't have? We're not one mesh fits all, and there has to be a benefit. How do patients broach that?
Okay, I'm going to go back a bit first, if that's all right, and then
Yeah.
I'll come on to mesh. So, for me, in a consultation, I walk the patient through the logistics of the operation, where I'm going to make a cut, how that cut's going to look, what I might be able to do about tidying up some of the skin and scarring and things like that, because we can often do a bit of that at the same time. And then I will walk through the CT scan normally with the patient and sort of just show them where the holes are and show them where the muscles are and where the problems are. And then I talk about the layers of the tummy wall, and then whereabouts we're going to put mesh, if we're putting mesh in, which we usually are. Mesh is, particularly in hernia surgery, pretty safe. It depends where it's put, and it depends on all the other things that are going on with the patient. So there's a lot of generalization here. But we know that if we simply take a hole in the tummy wall and pop some stitches in it, that usually isn't going to last. It might last for, a couple of years. And actually, for some patients, particularly coming towards the end of their lives, that might be all they need. Most patients, though, will need mesh somewhere to strengthen that tummy wall. And remember, mesh is not actually the thing that's strong. What happens is that the body has this reaction to the mesh to lay down a layer of scar tissue. And it's that layer of scar tissue that reinforces the tummy wall. So actually, the body's reinforcing itself, if that makes any sense.
Yeah.
In terms of types of mesh and things like that, that's a fantastic question. Essentially, we don't have a lot of real world data. What that means is there's mesh used in studies, and people say it's got this performance with this set of condition, this set of circumstances, and these patients did had this much of a complication or didn't have a complication. The problem with that is that's not real world, and that's not lots of surgeons all over the place using mesh under different circumstances. And what we really need is what we call registry data. So that means that all patients, regardless of where they're operated on or by who they're operated on, have their data put into a database, a registry, but that registry monitors outcomes. And that's done through the patients reporting their outcomes, and also through maybe tracking the patient number and picking up whether people are having repeated operations over a series of years. And by series of years, I mean decades.
Yeah.
And that's what we really need.
Yeah. Moving on from that, the BHS is about to launch the hernia registry, aren't they?
That's right.
Can patients request that their data is input into this registry?
Absolutely. I think promoting the registry to surgeons to say, my data should be in here because this will give you outcome data, but also this will add to a whole massive volume of data that will actually be able to significantly influence the way we perform hernia surgery and the type of technology that we're using. Things like mesh, like robots, like whether we fix mesh or not, all these like little bits can all be influenced by that registry data. But you need really high volume data, like hundreds of thousands of patients eventually, and to then be able to track those outcomes. And that's when you really understand what works and what doesn't.
That's great. So as we're waiting for surgery, we know about how important prehab is, don't we? And you and I have talked about this, but surgeons need to explain it, I think, a bit more to patients. Why are you actually asking them to lose weight? And why are you going to ask them to stop smoking and cut down on the drinking? What can patients, how do they approach that? Can they ask for a surgeon to recommend something to help them through that with the pain management? And
yeah, so surgeons do ask patients to get ready for surgery. And I think a good way of thinking about it is that, having major surgery, and this is now for any major surgery, really, it's not just about hernias. It's a bit like running a marathon.
yeah.
You wouldn't just put a pair of trainers on and try and go and do either a 10K or 26 miles tomorrow. You'd build up to that, wouldn't you?
Yes,
And
yeah,
your
absolutely.
body needs needs
Needs
to build
training.
like that. There's literally training.
Yeah.
So my patients, yes, I do ask virtually everybody to lose weight. And that's even people whose body mass index, their BMI is even just a little bit up. I always say, come down a little bit. And there's a number of reasons for that. And I'll come on to smoking and drinking and stuff in a second, but let's just talk about weight for a minute. Because that's probably one of the biggest ones with patients, and it's one of the hardest ones to change. The reason why we want people to lose weight is the technical aspect of doing hernia surgery. In other words, you've got a fixed volume inside the tummy, and you're suddenly going to reduce it by shutting the front of the tummy wall or by whichever part of the tummy wall that's come apart. Essentially, if you could think about stuffing a pillow into a tight pillowcase, you're going to make that pillowcase even smaller. And the technical aspect of doing it is much more difficult if a person's bigger and hasn't lost weight. That's the first thing to say. The second thing to say is there's really good evidence that the bigger patients are, the more likely they are to have significant problems with their wound. And that means that the wound comes apart, or they get a nasty infection, or there's a collection of fluid underneath it, or they might get a blood clot underneath it. All of these sorts of complications that can happen just with the wound alone goes up with weight. And the next problem is the chance of the hernia coming back also goes up. And it sort of goes up, like the bigger you are, the higher all these risks are. And also the risks of the general anaesthetic alone. So that's why weight is a really key sort of variable when it comes to doing hernia surgery. And as I say, I virtually say to everybody, you need to come down. And I normally give people a target as well. And I try to explain all of that to them. Moving on to sort of smoking and drinking. Drinking, I probably don't really focus on that much, except unless someone's really drinking, and then that's obviously a big issue anyway for their general health. But also for undergoing surgery, we'd also have to check their liver and things like that. Smoking, again, is associated with having wound problems, and it's also associated with the hernia coming back. You're 1.5 times more likely to have your hernia come back if you're a smoker than if you're not a smoker. And one cigarette alone reduces the blood flow to those bits that are trying to stick themselves together and heal after hernia surgery by 60%. And the less the blood flow, the more chance that's going to come back apart again. So the risk of wound complications and the risk of the hernia coming back goes up massively with smoking, as well as the risks of a general anaesthetic and things as well. So they're probably the two biggest things. Weight and smoking are probably the two biggest things. Diabetes is associated with problems after hernia surgery too, but of course, if weight comes down, diabetes will often sort itself out a bit as well, and diabetic control usually gets better.
Okay. I think you've already basically touched on this about scar, but I think that's important to patients as well. What is their tummy going to look like after the hernia? And for the big open surgeries, patients need to be prepared, don't they? Can they ask you if they their belly button is important to them to try and preserve that? Because I think we've had people who said, "Oh, I've lost my belly button," and they feel really shocked and upset about that.
Yeah, I try to, if I'm going to lose the belly, if I know I'm going to lose a belly button, I do try and tell a patient that in advance. I very occasionally have people say, I really want to keep my belly button. Sometimes you just can't do it. And what you don't want to do is try and preserve a belly button and create another problem. So in other words, the wound comes apart, we get a route for infection, or that little bit dies back, and then you get infection coming in. So sometimes there's a really good reason for getting rid of the belly button. Sometimes in hernia surgery, the belly button's disappeared off to one side or the other really quite significantly. And you say to the patient, you're going to lose your belly button. They're like, no, it's great. It's like it's gone over there somewhere. It looks weird. So just take it away. If you can give me a nice line down the middle and a nice shaped abdomen, I'll be happy. And I think for a lot of patients, particularly those really big hernias, they just want to feel and look better in their clothing alone, not perhaps maybe quite so much worried about what they might look like on a beach or something.
Okay. So what about if a patient doesn't feel they can approach a surgeon and ask questions? Now, I know what your answer is, and I know what my answer will be, but it isn't always thing. Do patients have the right to a second and third opinions?
If you can't talk to your surgeon, you need to find another surgeon. Okay, because that relationship's really
Yeah,
important.
it
This
is. It's
person's
a
going to be operating on you. Things may go wrong. And that's also part of the consultation process is to talk about, what are the risks of this? What's the likelihood of this happening to me? And I do try and give risks to patients, but even if it's a risk of 1 in 100, if you're still that one person, it still happens to you. And so, you've got to have that relationship with your surgeon where you trust them,
Yeah.
you ask them questions, and you trust them to look after you if things go wrong. And things go wrong to all surgeons. And it's that relationship's key. So yeah, definitely. If you can't talk to your surgeon, you need to find a different one. You do absolutely have the right to go and ask for a second or a third opinion. And I think if you've got something that's quite niche, so a really complicated situation, perhaps with medical history as well, this becomes an even more sort of more complicated situation, then absolutely going to a centre that's perhaps outside of the region in where you live to someone who just specialises in doing that sort of surgery on those sorts of patients is really important.
Yeah. I think as well, I think some patients will sometimes feel awkward in doing this, but we need to ask, don't we, about your experience in treating a certain hernia. For some hernias, especially like the peristomal hernias, or if they want an enmesh-free repair, they're better being done by somebody who does high volume of these and not just 1 or 2 a year.
Yeah, I think that's really key actually as well. You want to find a surgeon who specialises in doing that bit.
And it's okay to ask the surgeon
Yeah,
that.
definitely. And also say, what your results like. All right, you say you do mesh-free repair. What's your outcome data like? And there are times when I'm doing something that I don't do a lot of, probably because it's again a bit on the niche side, and I'll be able to say, look, I've done 10 of these and they appear to all have been fine. But that's not 200, is it? And I think being really honest about that In unusual situations, your surgeon will be able to say, look, here's what the national international data says, here's my training, and here's what my results look like. And someone should be really honest, be able to be really honest about that. And if you're as a patient, you're not happy, you need to go and find another surgeon.
Yeah. Okay. I always think there is always the risk that something's going to go wrong in the operating theatre. It's an operation at the end of the day, but it's more about how you deal with that and deal with it afterwards that's more important as well. Well, just as important.
Off hernia surgery is usually fairly
Yeah.
straightforward, and at least you know what you're doing before you get there. I think it's the aftermath, really. It's when
Mm.
things go wrong afterwards, and there's a problem afterwards, the risk of complications, so wound complications and things like that, but also other complications, perhaps people's hearts or lungs, having a heart attack after an operation, something like that. And it's about, how that's going to be managed, where you're going to have your surgery.
Okay. What about the recovery process? Do you advise patients on that?
Yeah,
Because
I do. I don't think there's a huge amount of data out there for all of this. People always want to know when they can get back to normal activity. And of course, normal activity varies from patient to patient. So when I said at the beginning, I asked lots of things about people's lifestyles because actually that's really important. So if you've got two little ones at home, not being able to pick your little ones up is
it's
probably
not
going
going
to
to
be
work.
virtually impossible. So people are like, well, is that going to be safe to do? Am I going to break this? Is it all going to fall apart on me? And so counselling patients about that. And yes, I'll always give really specific advice about, when you can go back to driving and things like that. There's not a huge amount of evidence out there for these things, but always give some general advice and very specific to people's lifestyles.
I think that's important, isn't it? That patients all also ask about that because what you know, then when something happens, you're not frightened about it.
Yeah.
We have patients who come to us and they're still in pain after a couple of weeks. You are still going to feel that.
Yeah, absolutely. And
And
it
it,
may stop to a year or more than that, twinges and little bits here and
mm,
there. Often it'll just settle down over time. And there is a small proportion of people who go on to needing painkillers long term. And yeah, chronic pain is something that's been really poorly understood in hernia surgery and the reasons for it. And we still don't really understand that. Again, this is where the registry would come in, and having patients reporting that as an outcome over time would be really important, because then we'd understand far more about what actually the impact of hernia surgery is on people's lives.
okay. What about watchful waiting? And we go back a bit then. Say somebody doesn't want this operation, they just do you do they can they still be monitored?
Yeah, and I've got some patients who are in that boat as well. Patients who've got hernias, perhaps they're much bigger patients who I've said I can't do anything for
Yeah.
this at the moment. And you asked me a little bit about that earlier, and I'll come back onto that in a second. The other group of patients who often end up with watchful waiting are older patients. Interestingly, as we get older, we do lose our muscle mass, and as soon as that sort of starts to set in our lifetime, the chance of having a problem from surgery goes up massively. In fact, it's a really big risk factor. So I've got it's not so much about age, it's about the physiology of that patient and about what they're able to do. So if they're 75 and they're still doing 18 rounds of golf, or 79 and still doing 18 rounds of golf, great, you can have your hernia surgery. If you're 79 and you can just about walk to the gate and back again, and that's all you can do, you probably shouldn't be having an operation, because you're in that stage of life where actually a hernia operation is going to be a bit too much, and it's going to massively impact on your independence and your ability to get back to where you are now. We know that the older patient group never quite get back there again if they have a really big operation. So I think that's really important. Again, it's about lifestyle and what people's functions are.
Yeah, managing their expectations. So I think as patients live with a hernia, there's certain things that can help them feel better. Do you recommend that do you have a hernia nurse or anybody who can keep in contact with them?
I don't. I'd love one. I don't. So it's all very much me
Yeah,
at the moment. That's not true for all centres though, and
no,
that's not true for all surgeons. So yeah, there are centres that will have specialist nurses working there.
and
Yeah.
can keep in touch, but they can also recommend things like support wear and physio and pain control and keeping how to keep mobile and exercise and everything.
Yeah, yeah, yeah. And I think And I think actually we didn't touch on exercise, but I do always say to patients, you've got to go and buy a pair of trainers and just, like, well, it's really hard. I know it's really hard, but even if you go around the block and then tomorrow you go around the block twice, and then you go around the block,
Yeah.
3 times next week, and then you go, and you just keep building it up. It doesn't matter. All the while you're doing a bit of exercise, you're actually building that muscle mass. Because again, building that muscle mass is really important for getting over an operation. So our bodies use our muscles. They sort of essentially your body sort of eats away at your muscles and takes some of the reserve in the muscles out when it's trying to heal and get over a major operation.
Yeah.
The
And
other
then I
thing,
think, sorry, go on.
yeah, the other thing you wanted to ask me about earlier, which I didn't answer for you, was about sort of optimization. Is there anything out there to help? Obviously, when we talk about weight loss and things, we talk about Weight Watchers and all of those sorts of things. But there are things like the Active Life program and things running through general practice and through the NHS. It's accessed via general practice, where it's about weight loss, it's about exercising, it's about stopping smoking, and really getting fitter. Things like the weight loss drugs are bolted onto those sorts of programs, but there'd be very specific criteria for them. And eventually, of course, at the end of all of that, there's also bariatric surgery. But those programs are accessed through general practice. It's always worth asking your GP. If you're getting a referral for a hernia surgery and you've got a big hernia and you're thinking they're going to ask me to lose some weight and get fitter, then absolutely go through your GP. And I'll often write back to GPs and say, is there anything you can access to help this patient?
Right. The other thing we have is if a person's pregnant, are there any specific questions that they should be asking the surgeon?
Um, I don't
Should
know.
they? I mean, I think it's things like will the hernia impact on delivery? Um, and with aftercare and things like that. Obviously, unless it's an incarcerated hernia, you prefer to get all the babies out of the way first, have all the pregnancies before the hernia is repaired.
Yeah, definitely. I think for really big abdominal surgery and people who've got sort of hernias through cesarean sections and things like that, if you've got a hernia through a cesarean section and you're having another cesarean section, that's going to take a bit of thought. People who've got sort of lots of ladies when they're pregnant get a bit of a hernia through the belly button. That's really common. Often it will settle down a bit afterwards, and you may or may not notice it afterwards. Again, we wouldn't repair that during pregnancy, and we'd usually say, look, have your family, and then we'll sort it out afterwards.
Yeah.
If for patients who have got a situation where there's bowel stuck inside their hernia, and that's sort of that it's like incarceration or strangulation is what we'd normally say there. And they need emergency surgery. You're pregnant, you're not pregnant, it needs doing.
It's doing, yeah.
Yeah, so we would just get on with it. That's a pretty unusual situation, though.
Yeah. Okay. Well, I can't believe it, Stella. It's 1:30. We've come to the end.
Wow, have we covered everything?
I think we'll have to have you back.
Talk too much. Did we cover everything? Was there anything else that was on
I
there?
think it's just with just one final question about how would a patient approach you if they had allergies?
Are you talking about concerns about allergies to mesh and things like that?
Well, if they have a lot of hay fever, a lot of different types of allergies, they're allergic to a lot of products.
I've not had a situation where anyone's been allergic to anything that I have used, either stitches or mesh. I mean, the stuff that we use is pretty inert. I'm not going to say no one's ever been allergic to it because I'll inevitably be wrong. But if someone was concerned about having an allergy to something that we're going to use, be that anything from like skin preparation medication, some people are allergic to iodine, for
Yeah.
instance. So that's really important to point out. It's really important to tell your surgeon and anybody else who's asking you questions about your operation what you're allergic to. And if you're really concerned, you can be referred on for allergy testing. Whether they can test for suture materials and meshes and things like that, I just don't know the answer to that. I'd have to ask that question.
Okay, well, that's fine. Well, that's it. Thank you very much, Stella, for joining us. That's been really interesting, really good. It's been lovely to talk to you, and I'm
Thank you ever
sure
so much for
we'll be
having
asking you to come back again.
me. Yeah, that'd be my pleasure if I can ever be of help again. But yes, thank you
Thank
for
you.
having me.
No, thank you very much, and thank you everybody for joining us tonight. Thank you.
Bye now.
Bye.